The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Dr. Emily Casanova is a neuroscientist who has studied autism for more than a decade and more recently has been studying the overlap between autism and hereditary connective tissue disorders like Ehlers-Danlos syndrome. One of her current efforts concerns the study of an Ehlers-Danlos phenotype in carriers of Fragile X premutation and autonomic disorders in this population. Dr. Manuel Casanova is the SmartState Endowed Chair in Childhood Neurotherapeutics and a professor of biomedical sciences at the University of South Carolina School of Medicine in Greenville. And now I will turn it over to Dr. Emily Casanova.
Hi, good afternoon, or well, almost good afternoon, everybody. Yeah, no, we're in the afternoon, at least for those on the East Coast. So today, my husband and I are going to be talking about how the autonomic nervous system may govern or influence anxiety in autism. So I know this is a growing topic of interest, so hopefully we got a lot of listeners out there. So I'm going to talk about, hopefully this slide doesn't scare you a little bit, okay? We're going to have a tiny neuroanatomy lesson, very basic, just so we're kind of all on the same page. I'm going to talk a little bit about the design of the central nervous system, and then talk a little bit about the peripheral nervous system, which is what we're going to focus on mostly for this talk. So over here, I'm going to take my little laser pointer here. Over here, we have the brain. Okay, and we've got the spinal cord coming out of the brain, and we've got some nerves coming from the spinal cord. This is the central nervous system. All right, over here we've got a cross section of the spinal cord. You're just kind of taking it from the top and the bottom, and you're just looking at it top down. And from the back here, the dorsal area, as I said, that's closest to the back. All right, that's facing the back. You've got sensory neurons coming in and synapsing on these cells here. And from the front or the ventral region, you've got these motor neurons that are coming out. They've got their cell bodies within the gray matter in the spinal cord, and they're sending their axons out into the peripheral system. So that's kind of the basic setup and how your central nervous system or peripheral systems communicate with each other. So, oops, too far. And so here we've got, as I said, with the sensory, this is information that's entering into the central nervous system, and from the motor component, you've got information leaving. So that's the basic setup. Now, as far as the peripheral nervous system, again, we've got sensory and we've also got motor. Yes, motor is a little bit part of the central nervous system too. It gets a little blurry there. But just for these purposes, we tend to divide the peripheral nervous system into these two branches as well. And the motor is what we're interested in here. Because this is one of the subdivisions of the motor system is the autonomic nervous system, okay? You've got the somatic nervous system that's innervating skeletal muscles and making them move, but then the autonomic nervous system is involved in moving a different type of muscle known as smooth muscle. That's, you know, a lot of smooth muscles within the cardiovascular system, in the gut, things like that. And then you also have the autonomic nervous system innervating glands. So this autonomic nervous system is then divided into two further subdivisions. We neuroanatomists love to make our divisions in these little boxes here. And so we've got the sympathetic and the parasympathetic. And so we're going to talk a lot about these two today. These are the main two branches of the autonomic nervous system. So over here, as I said, we've got sympathetic. That is your fight and flight response. And so that's associated with things such as pupil dilation, increases in heart rate. You've got a dilation of the lungs so that you can breathe better. You have a decrease in activity of the gastrointestinal tract, because obviously if you're fighting and you don't want to have to stop and use the bathroom. You also usually have vasodilation, so a dilation of your blood vessels. Now over here at the parasympathetic, that's the rest and digest. That's your central nervous system telling your body to calm down. All right, and so you have things like pupil constriction, a slowing of the heart rate, you have vessel constriction, and also you have a stimulation of the digestive tract. So these are very relevant, of course, particularly in autism, where we often have a lot of gastrointestinal problems, especially with slow motility or constipation. Obviously, the sympathetic and parasympathetic nervous systems are playing integral roles in controlling that. So here they tend to, this fight and flight and rest and digest response, they tend to be in diametric opposition to one another. Not always, there are some exceptions, but for the most part, when one goes up in activity, the other tends to come down. So you can also think of it a little bit like a tango. As the sympathetic nervous system activity goes up, the parasympathetic goes down. Okay, so I'm going to review a little bit about what has been found in autism in terms of abnormal autonomic activity and the symptoms that tend to go along with that. So by and large, autistic people tend to have a higher at-rest sympathetic or fight and flight activation. This tends to be evidenced by things like a higher resting heart rate. So even just sitting or resting, an individual with autism tends to have a higher heart rate on average. Also things like increased pupillary size and also a higher respiration rate. So they tend to be breathing faster. Autistic people also tend to have a higher sympathetic or fight and flight activation during certain stages of sleep. So here we're looking at two of the non-REM stages, stage 1 and stage 2, as well as REM sleep. All three of those autistic people tend to have a higher sympathetic activation. So these are stages, especially in stage 2 and stage 3, where, you know, you're supposed to be having a lowering of sympathetic activation. You know, the body temperature is supposed to be dropping, heart rate is supposed to be dropping, the muscles are supposed to be relaxing, blood pressure drops, those sorts of things. But in autistic people, that tends not to occur. So, or at least as severely. And so they may not be getting as good a quality of sleep, which probably many of you either being on the spectrum yourselves or being family members on the spectrum may be very familiar with that feature. There can be a lot of sleep problems with those on the spectrum. So autistic people also tend to have a higher sympathetic activation during interaction with other peers, with social interactions. And that's probably not terribly surprising to a lot of you. There's a lot of social anxiety that tends to go along with autism. So that tends to be reflected by some of that higher sympathetic activation, that adrenaline, that level of excitement. Interesting thing, researchers have found that when pets, so when animals are involved in that social interaction, the autistic kids' hyperarousal, the sympathetic hyperarousal, tends to go down, so it's not as extreme. So these animals are potentially a really good therapeutic mechanism, not only probably for just, you know, general self-calming, regardless of whether they're interacting socially, but also as a potential therapeutic method to use in socialization. So, you know, animals, I'm a big animal lover personally, and I find that as well. I don't know about you, but I feel a lot calmer when I have my fur babies around. I think a lot of people can appreciate that. So I'm going to talk a little bit about stimulatory behaviors or stimming. All right, and we know, you know, these are very common in autism. All right, and autistic people often use these stimulatory behaviors, researchers have found, in order to reduce their sympathetic arousal. So their sympathetic nervous system tends to be overactive, and they will use these physical gestures or any kind of stimulatory behaviors to reduce that activation. So it is a self-therapeutic method. So I think that's very important to keep in mind. Interestingly, at least when we're talking about individuals who have hyperarousal of the sympathetic nervous system, these stimulatory behaviors probably could be better thought of as calming behaviors, since they're trying to actually calm the sympathetic nervous system down rather than stimulate it. But there does seem to be a small percentage of autistic people who do have low sympathetic activation, just generally. And they tend to find more sympathetic stimulation when they're engaged in self-injurious behaviors. So again, these stimulatory behaviors in terms of self-injury are actually helping them to regulate their nervous system. Unfortunately, it also comes with the downside of injury, of course, which is why we try to find, hopefully, alternatives for that need for stimulation. And so kind of on the flip side, these could kind of be thought of as stimulatory behaviors in the true sense of the word. Autistic people also tend to have lower sympathetic activation in response to certain stimuli. One of those includes typical fear eliciting responses. So this has particularly been studied in younger kiddos on the spectrum. And in general, there may be situations in which most children, this would elicit a fear response and they would be more cautious and things like that. But some of these autistic children tend not to have that traditional fear response. And so they may obviously engage in behaviors that are potentially dangerous, as probably many of you parents out there are familiar with. Autistic people also tend to exhibit a lower parasympathetic, so that rest and digest activity during the morning hours. And I think that's probably something a lot of us could appreciate anyways. This is probably a general human trend. It's just more extreme in autistic people. So it may be even more important for these individuals to engage in stimulatory behaviors and routine and just kind of have a nice quiet morning while their parasympathetic nervous system is kind of catching up. And that's probably the case for a lot of people who may have anxiety issues as well. And talking about anxiety, autistic people with lower parasympathetic tone or activity do tend to have greater symptoms of anxiety. They also, and that is across the board, I will say, for people, regardless of whether they're autistic, even individuals with anxiety disorders tend to show a lower parasympathetic tone. They also tend to have poor social skills. And finally, these do tend to associate with more lower gastrointestinal tract problems, such as constipation. This is particularly common with individuals who have experienced regression or skills loss. So I'm going to talk a little bit about the sensory system here, just for comparison with the autonomic nervous system. This was a very small study, and it was a group of individuals. They looked at in a couple of cases of autistic kiddos who had reduced pain sensation, which is a commonly reported symptom in autism, that there was nerve fiber loss when they took a skin biopsy. They found nerve fiber loss of these very small unmyelinated, what are known as C fibers in the skin of these autistic kids, suggesting that some of the sensory dulling is actually due to a physical loss of nerve sensation. And it's not necessarily just coming from within the central nervous system. So there may also be effects to the peripheral nervous system. Interestingly, and the reason that I'm bringing this up, because I know we're talking about the autonomic nervous system, that's our focus here, is that this same type of small C fiber is also involved in the autonomic nervous system. So there's some possibility that if the C fibers within the sensory system in the skin are being affected, it's also possible that the C fibers in the autonomic nervous system are also experiencing a loss. So we do know that, and this is something that's called small fiber neuropathy, And we do know that it's been implicated in gastrointestinal motility disorders, so constipation, maybe slow emptying of the stomach, things like that in more extreme cases. Sleep disorders, of course, obviously pain disorders, as you can imagine, when I talked about reduced pain sensation, and then also alterations to temperature perception. So each one of these has been implicated in small fiber neuropathy. So, and I'm probably better known for some of my work in terms of Ehlers-Danlos and autism and that overlap. And I will say that we do see that same kind of small fiber loss in Ehlers-Danlos and the hypermobility spectrum disorders. So if you're interested in more of that just kind of general overlap, I don't really talk about the neuropathy per se, but I did do another webinar for ARI on that general overlap topic if you're interested in looking that up. And also too, we have other materials that we've put out there in terms of this overlap between autism and Ehlers-Danlos. Just kind of sneaking this in here, but you know, and we've done that through ARI and Spectrum News as well as Mighty. And then I do have a science blog down towards the bottom here that I tend to keep up, and I post things about autism and EDS. So anyways, I'm going to hand the lecture over to my hubby. He's great. I know you all enjoy him, and we'll see it. I'll see you at Q&A, guys. All right.
Hi. Glad to be here with all of you. Now, as Emily said at the beginning of this lecture, after the autonomic nervous system receives information about our body and its environment, it provides a response by activating two of its branches, the sympathetic and parasympathetic divisions. Sometimes researchers add a third branch to the autonomic nervous system, the enteric branch, also called the intrinsic nervous system or the second brain. We will confine our comments to the sympathetic and parasympathetic nervous system without approaching the enteric nervous system. This part of the lecture will emphasize the clinical aspects of autonomic dysfunction in autism. Hopefully the listener will understand that symptoms will vary greatly from one individual to another. Some patients will exhibit one or a few symptoms, while others may actually suffer from a very large number of them. Presenting symptoms may be quite common, like feeling your strength being sapped by the hot weather, while others may feel particular to that individual, like the absence of goosebumps in cold weather. In autism, signs of autonomic dysfunction include altered skin conductance, which is also known as the electrodermal response, a lack of heart rate regulation to potentially stressful stimuli, a change in the pupillary size, also called baseline or tonic pupillary size, and sleep disturbances. Other symptoms that may indicate the presence of an autonomic disorder include dizziness and fainting, usually upon standing, orthostatic hypotension, sweating abnormalities, and digestive difficulties such as loss of appetite, bloating, diarrhea, constipation, and difficulty swallowing. As you can see, the parallelism to anxiety is quite striking. Indeed, common signs in both anxiety and autonomic dysfunction include feelings of nervousness and tension, sweating, and an uneasy stomach. The electrical resistance of an object is a measure of its opposition to the flow of electric current. The inverse of resistance is conductance, by which I mean the ease with which electric current passes through a material. The skin responds to an electric current, meaning how easily it passes current through the same, is called the electrodermal response. This is one of the physiological indicators utilized as part of the polygraph for lie detector test. In autism, the electrodermal response is sensitive to changes in arousal and emotional states. This measure is well tolerated and has good potential for being streamlined into wearable devices, which could be embedded within clothing or possible long-term monitoring outside the laboratory or clinical setting. The electrodermal response measures to a great extent the activity of sweat glands. Because of the high density of sweat glands and ease of access for examination, electrodes are usually placed on the palms and the fingers. In this way, the electrodermal response may be used during biofeedback training in the management of anxiety. Heart rate data can also be collected from a sensor placed on a fingertip. Heart rate variability is literally the variance in time between the beats of your heart. The period of time between successive heartbeats is known as the RR interval, named for the heartbeat's R phase, which are the spikes that you see on the EKG. So if your heart rate is 60 beats per minute, it's not actually beating exactly once every second. Some heartbeats will happen at a faster or at a slower rate, and this variability is normal. Older people and those with sympathetic overarousal, like autistic individuals, they have diminished heart rate variability. In addition, diminished heart rate variability is associated with an increased risk of death and cardiovascular disease. Now, I have always found this to be of great significance, as sudden death in autism, especially when coupled to a history of seizures, appears to be much more common than expected as compared to the general population. In autistic children, a larger pupillary size, one slower to constrict when exposed to light, is thought to reflect a sympathetic system that is in overdrive. The large pupillary size is often accompanied by an elevated heart rate in patients that appear to react to stress more readily than controls. I have often said that the eyes, or better yet in this case, the pupils, are the windows to the autonomic nervous system and help in providing an easy way for gauging some health-related aspects of an autistic individual. As Emily has said, many people with autism have difficulty falling and staying asleep. Sleep and the autonomic nervous system interact as a two-way street. Sleep induces profound changes in the functions of the autonomic nervous system, and disorders of the autonomic nervous system adversely affect vital functions during sleep, like circulation and respiration. In autism, these autonomic symptoms like sleep disorders may be triggered by stress, psychological trauma, as well as by more subtle exigencies like dehydration. That's why we all have to be detectives when we find these symptoms. Although not considered a core feature of the disorder, anxiety has been reported in 11 to about 84% of autistics. The average usually given is 40%, which is way higher than the 18% cited in the general population. My own belief is that autonomic dysfunction underlies the chronic generalized anxiety experienced by a large portion of autistic individuals. This is of importance as measures of autonomic arousal and cardiac response regulation, they could be useful in distinguishing subgroups of autistic individuals and help in guiding how we treat them. Now, anxiety is a physiological and emotional response to a perceived threat. It is the feeling of fear and apprehension about what is to come or whatever may be happening. Chronically, it increases the risk of high blood pressure, heart disease, and it can also have an impact on a person's mental health. Anxiety activates the autonomic nervous system, the fight and flight response that Emily spoke about, manifesting itself as tachycardia, palpitations, shallow breathing, shortness of breath, chest pain and tightness, sweating, etc. Because these outward physical symptoms of anxiety may be especially prominent in children with autism, and given their communication problems, things that we can measure, put a number on them, either in clinics or in the laboratory, may be the only clues that something is bothering the patient. These measures may also help us gauge the outcome of an intervention. Now, agitation and anxiety are both common symptoms associated with catatonia. Catatonia is said to affect as many as 12 to 17% of adolescents and young adults with autism. An increasing number of cases of catatonia in autism have been reported throughout the world over the last 15 years. Although catatonic symptoms are said to include rigidity, waxy flexibility, stupor, mutism, less attention is given to symptoms pointing towards autonomic dysregulation, and by that I mean hyperthermia, tachycardia, tachypnea, hypertension, level blood pressure, and even profuse sweating. Now, the following clinical history in this slide is actually quite illustrative. My son had suffered a terrible breakdown. He was constantly pacing the house with his arms bent at the elbows and his hands pointing downwards and his head flexed back. He was hitting his whole body with great force and extremely distressed. Eating a meal could take a very long time, from 2 to 5 hours. This went on for 3 months, and it was soul destroying. Now, this is one of my pet peeves, but I have to believe that some of these cases of catatonia in autism are related to the use of neuroleptics. Now, I know that neuroleptic malignant syndrome is considered to be a drug-induced form of catatonia. But in here, I would like to mention cases of catatonia that receive neuroleptics chronically during their childhood. And if any of the listeners has had a similar experience, please email me. I'm very interested to hear from you. Catatonia is usually treated with benzodiazepines and sometimes with ECT. Curiously, I will be talking about transcranial magnetic stimulation, TMS, later on in this lecture as a treatment for autonomic dysregulation. I think that both modulatory techniques, ECT and TMS, may help reboot the brain and acquire more efficient brainwave oscillations. I am hoping that these interventions may also be of help in cases of secondary dysautonomia like diabetes and Parkinson's disease. Now, anxiety symptoms are sometimes difficult to communicate by an autistic child. So instead, in autism, anxiety may be manifested as recurrent fears and worries, difficulties falling asleep, or by being scared about going to school. In some autistic patients, anxiety may also be manifested as repetitive behaviors that appear to serve no function to the child. And by that I mean shredding paper or clothing, jumping, spinning, head banging. Indeed, I would say that stereotyped and repetitive motor behaviors, core features of autism, have been suggested to serve as a self-medicating attempt at reducing sympathetic activity and its consequent arousal and anxiety, just as Emily mentioned before. Now, this is my clinical purpose for the lecture. Whenever I see an autistic individual in my office who's beginning to show signs of an impending meltdown, a patient who's irritable, crying, engaging in stimming behaviors, I usually take a small beanie bag from the pocket of my lab coat and place it over their head. I think that the pressure effect lets them regain a sense of their body plan. But the main thing is that it helps calm the patient down. I must add that having beanie bags of different colors and giving the patient the ability to choose among them is of importance for the therapeutic effect. The other thing that I try to institute is so-called parasympathetic breathing. This is when you inhale normally, but you exhale fully through a straw. Doing this exercise for about 5 minutes, 3 times per day, may also prove therapeutic for those patients suffering from chronic anxiety. I must also add that the difficulty in communicating the internal feelings of anxiety by an autistic individual may involve an abnormality of interoception. And by interoception, I mean that a sensory system that allows us to feel what is going on inside of our bodies, giving us the ability to recognize signs of getting tired or fatigued, telling us whether our heart is beating fast or slow, how we are breathing, or whether we have an urgency to go to the bathroom. The following statements from autistic children in Kelly Mahler's book are illustrative. I do not realize that I am getting angry until I am exploding with anger. By then, it's too late. I can't control it. Or another one. A lot of times, the inside of my body feels like one of those glitter timers. The ones that you can shake and the glitter goes every which way. I feel so many different things at once and I am not sure what is important. It is very overwhelming. The interoceptive system has specialized cells or receptors located throughout most of the tissues of the body, including the heart, kidneys, bladder, skin, glands, and so forth. These receptors gather information and send it to an area in the brain that is called the insula. The insula uses the incoming information to help you identify conditions and physiological processes like pain, hunger, fullness, coldness, nausea, physical exertion, sexual arousal, anger, calmness, distraction, or fear. You know, in the end, interoception allows you to answer the question, how do I feel? Emotions are influenced by assessment of bodily arousal via the sensing of visceral signals from the inner body, the sense of interoception that we just spoke about. And by contrasting the same with information coming from both exteroceptive senses, the visual, auditory, vestibular, and proprioceptive signals, those signals that have to do with body movement and position. Emotional manifestations are dependent on central representations of bodily arousal, and share common neural substrates. In particular, the anterior insula subserves both interoceptive accuracy and emotion processing. This region of the brain plays a major role in supporting subjective feeling states. It also helps regulate the introduction of feelings into cognitive and motivational processes. It is not surprising that the insular cortex has been implicated as an anatomical substrate for emotional states. As you would expect, it is indirectly supported in this regard by activity from the amygdala and hypothalamus, and directly through the anterior cingulate cortex, orbitofrontal region, and the dorsolateral prefrontal cortex, the usual players. The anterior insula and ventromedial prefrontal cortex contribute to the integration of visceral afferent information. Emotional deficits in autistic children are associated not only with difficulties in recognizing the emotions of other individuals, but also in dysregulation of their own emotions. It is possible to propose that emotional deficits expressed by autistic children may originate in impaired interoceptive processing and misjudgment related to their own arousal level. I would emphasize something that may be somewhat speculative as of present, that many of the behaviors, emotions, and physiological manifestations that we observed in autism are the result of a dysregulated top-down process stemming from cortical influences on the limbic system and brainstem centers over the autonomic nervous system. Autonomic arousal is generally understood as a shift in visceral state to facilitate ongoing or anticipated motor actions through an increase in cardiac output and blood flow to muscles, along with a simultaneous reduction in blood supply to the internal organs. This process is associated with a general increase in sympathetic activity, particularly to the heart, blood vessels, and skin, and is typically preceded by a more rapid withdrawal of parasympathetic activity. The triggering of this fight or flight response usually stems from a threat in the environment. In the case of an autistic individual, this threat may be a change in the everyday routines, lack of sleep, or having to participate in a socially charged situation. Studies of skin conductance in autism have demonstrated several manifestations of overarousal. Since electrodermal activity is controlled solely by sympathetic inputs, that is, by sympathetic innervation of the sweat glands, these changes are indications of an elevated sympathetic tone. Unfortunately, these results do not tell us anything about the parasympathetic nervous system. Again, I'm going in a tangent to another one of my pet peeves, but the sympathetic and parasympathetic branches are usually characterized with adjectives. We usually talk about them as the sympathetic or parasympathetic nervous system. But this is a misnomer, as neither one of these would be able to successfully work in isolation as a system. The only way that they can be successful is when they work together as the autonomic nervous system. The usual analogy used in explaining the action of these branches portrays them as parts of a car. The accelerator for the sympathetic and the brake for the parasympathetic. You can use the accelerator until you start to feel as if you are losing control. And it is important then to learn how to use the brakes, as it prevents you from losing control and getting into an accident. I prefer to think of these branches of the autonomic nervous system as Sherlock Holmes and Dr. Watson. You can't picture one without the other, and they both need to work together. In essence, they complement each other. So again, to reiterate, knowing only the results of sympathetic activity in autism, which can be done readily and easily, does not allow us to judge how the autonomic nervous system is working. You need information about both the sympathetic and parasympathetic nervous branches. The heart is dually innervated by the sympathetic and parasympathetic nervous system, acting to accelerate or decelerate heart rate. Information of either one by themselves is not informative of how autonomic nervous system influences cardiac function. Therefore, it is useful to use both electrodermal and cardiac indices together to better judge the role of the autonomic nervous system in the arousal observed in many autistic individuals. Cardiac parasympathetic hypofunction has been reported in autism in association with evidence of increased sympathetic tone. Both respiratory and cardiac vagal hypofunction in autism may suggest brainstem dysfunction, or better yet, diminished top-down control of the cortex over limbic and subcortical structures. The medical literature suggests that low parasympathetic activity can help explain the chronic sensory hyperarousal state and some of the social communication difficulties in autism. These findings allow us to make extrapolations in regards to putative cascade series of events going from autonomic parameters to arousal, anxiety, as well as to some of the core behavioral deficits of autism. This is a photograph of the screen of one of my favorite oscilloscopes sitting on top of a workbench at my home. It's my baby. The upper channel displays a waveform meant to imitate an EKG. The x-axis portrays the time and the y-axis is amplitude of voltage. I may be tracing from an arbitrary waveform generator, not a real EKG. This upper channel allows us to study linear parameters in the EKG that can be discerned in the time domain, like heart rate and its variability. The lower channel illustrates a frequency analysis of the same EKG-like tracing that is shown in the upper channel. The x-axis is the frequency and the y-axis its power. In the spectrum of frequencies shown, one can arbitrarily divide them into high and low frequency components. Spectral analysis of heart rate represents a measure commonly used in psychopathology research for assessment of cardiac autonomic control. An attenuation in the power of the high frequency component is sometimes taken as an index of parasympathetic control and also as an indicator of a limited psychophysiological flexibility. Deficits in the modulation of the high frequency range in different social tasks have been found in autism. Meanwhile, neurotypical children suppress the high frequency component more than children with autism. Autistic children, on the other hand, demonstrate dampened heart rate reactivity and unusually small deceleratory heart rate response, and generally low cardiac reactions to auditory stimulation, including socially relevant speech phrases and tones. In many of our transcranial magnetic stimulation or TMS clinical trials, we have found that at baseline, Autistic individuals show an accelerated heart rate in association with lower heart rate variability. This was indexed by an elevated low frequency to high frequency ratio of the heart rate. The ratio is also known as the cardiac autonomic balance index. The findings suggest poor parasympathetic tone. These children also evidence low standard deviation of heart rate and a high electrodermal skin activity, findings which, when taken together, serve as good indicators of baseline levels of excessive sympathetic and reduced parasympathetic activity in autistic individuals. In several clinical trials, our group has shown that applying low-frequency transcranial magnetic stimulation to the prefrontal cortex of autistic individuals normalizes autonomic parameters with an additive effect noted with increasing numbers of treatment sessions. This takes advantage of something we have spoken about before, the top-down control exerted by the prefrontal cortex over both limbic regions and the autonomic nervous system. The results of the intervention are manifested as a reduction in the heart rate, seen as an increase in the RR interval and as increasing heart rate variability. We are hopeful that this intervention will also prove prophylactic in preventing sudden cardiac death and in treating these autonomic symptoms in autism. Our results suggest that measures of autonomic arousal, as well as autonomic cardiac regulation profiles, could be useful in distinguishing subgroups of autistic individuals and how we treat them. Indeed, there are ongoing clinical trials using beta blockers, Endowed, in autism as a way of treating overactivation of the sympathetic nervous system by blockading its effect on the heart. It has been suggested that Endowed, propranolol, may have beneficial effects for treating the emotional, behavioral, and autonomic dysregulation of children and adolescents in the autism spectrum. Drug trials like this may serve to better target the underlying pathology and avoid many of the short and long-term side effects provided by anxiolytics. In addition, in different articles, our group has shown that a TMS provides for an amelioration of autonomic parameters that is directly related to behavioral improvements. Thus, changes in autonomic parameters correlate with significant improvements in repetitive and aberrant behavior scores. These behaviors are, in many occasions, what we see as manifestations of anxiety in this patient population. We're also very interested in pursuing many of our patients' comments that they have also noted improvements in sleeping behaviors as well as gastrointestinal manifestations with TMS therapy. Now, in summary, anxiety in people diagnosed with autism needs to be recognized as directly linked with atypical autonomic control and excessive sympathetic arousal. The autonomic nervous system is responsible for multiple physiological responses, and dysfunction of this system is often recognized as contributing to the cognitive, affective, and behavioral responses observed in children with autism. Typical autonomic arousal has been used to explain some of the core symptoms of autism, such as repetitive behaviors and avoidance of social interaction. This is an immensely important subject with practical applications that can immediately provide for changes in the quality of lives of those affected. For those interested in additional information, please read our latest 2 books on autism, Autism Updated, Symptoms, Treatments, and Controversies, or Defining Autism. Or follow us in our blogs, Cortical Chauvinism and Science Over a Copa. Thank you for listening to us and giving us your attention. God bless you all.
All right, thanks, Manny. Thank you for that great presentation from you both. So we do have a lot of questions today, so I know Emily's going to come back and join you.
There I are. Okay.
Can you see both
Are
of
we,
us?
are we both visible?
Yep,
Okay.
you're both on screen. So
Great.
thanks again. We have many, many questions. The very first question that I will share is about getting services for TMS and these different interventions. If a parent is looking for that support, where would they start?
Yeah, you know, that's a very important question and one that I have received many times. Unfortunately, TMS, transcranial magnetic stimulation, remains in the research round, and it hasn't been approved by the FDA for treatment of autism. There are many trials, but many of them, by far the vast majority, they deal with very small numbers. So there's a need for a phase 3 trial that you can treat hundreds and hundreds of patients in order to deliver the size effect that is needed for the FDA to take actions. So right now, if you wanted to pursue this for autism, I would say that you can check clinicaltrials.gov, and you will be able to explore within the internet all of the trials involving autism and TMS within the United States. Hopefully that will help. We used to do a lot of clinical trials, but we had to stop as of present because of COVID and so forth. But we never charge under a research setting money to any of our patients, and we treated hundreds and hundreds of patients. I would say that there are commercial enterprises where you can get the treatment, but you will be paying a bundle. And in a certain way, I really don't recommend personally any of them. I think that having a commercial interest rather than a patient interest biases the treatment overall. And I have heard many sad stories about patients that have been financially bankrupted because of this. So be very careful. But I have high hopes for TMS because, as I was telling you in this lecture, it's not only about core deficits of autism. It's not only, I had a previous lecture over at ARI about TMS, and I was talking about how it addressed the pathology of the condition. But now we're talking about prophylaxis and preventing autonomic dysfunction, primarily in terms of probably even acute cardiac death, which is extremely common in patients with autism. So it's something that needs to be pursued and done more research, and hopefully with the backing of patents, it can happen. Thank you very much for that question.
And I'd like to add too that we're hoping in future also to try and expand to utilizing low frequency RTMS in the treatment of autonomic disorders in some of my area in terms of Ehlers-Danlos and some of these hereditary connective tissue disorders. Because again, there's not a lot of great treatments out there. So, but cross fingers in future we'll be able to get that work going.
Mm-hmm.
Emily, we've got a couple questions about fast breathing rates and hyperbreathing. So this person's asking, do you have any ideas about how that directly connects to the dysfunctional ANS? This parent points out that it also happens in Pitt-Hopkins syndrome.
Yeah.
And some kids are diagnosed with autism too. So.
Right. You know, I know I talked a little bit about it, and Manny talked about in terms of more rapid respiration. That's definitely can be definitely a sign of kind of hyperarousal of the sympathetic nervous system, so that fight and flight branch. And so definitely, even though we're talking about kind of, for want of a better word, idiopathic autism, you know, autonomic disorders are definitely also very common in a lot of different forms of genetic syndromes. You know, this is it's just a very common thing that these issues funnel through. You know, it's kind of a common part of this syndrome, and I would imagine is also extremely common in different forms of intellectual disability as well. So a lot of these neurodevelopmental conditions have autonomic disorders as a common phenotype. So yeah, so this more rapid breathing rate, this respiration, higher heart rate, things like that are all very, very common classic symptoms of sympathetic hyperarousal. So at that rate, sometimes it really depends on what is causing it. But again, some of the things that I know Manny talked about in terms of breathing through a straw, you're kind of trying to strengthen the parasympathetic branch, try and stimulate that a little bit more. For individuals who are able to do it, meditation is also another route. You know, regular meditation is excellent. Another thing that's often used in the Ehlers-Danlos community, especially with certain types of autonomic disorders like that are posturally related. Also to cardiovascular exercise can be very helpful for those individuals who are physically able, that is. Sometimes that's not always possible, unfortunately, but regular cardiovascular exercise can also help to tampen down that extreme imbalance. It won't necessarily fix it, but it does help to alleviate it a little bit. And that's definitely something to keep in mind with, you know, with a lot of people on the spectrum, especially kiddos. It may be difficult to get them engaged in cardiovascular exercise. So, you know, but that is certainly something to focus on, you know, exercise when it's physically possible. I want to stress that when it's physically possible and it's not causing more injury than it's worth, of course, it is an important component of helping to regulate this autonomic nervous system.
You know, I would like to add, because what Emily said can be expanded upon. I mean, there are so many important things in what she was saying. And one of them is actually the presence of comorbidities in autism. Usually when an autistic individual comes like to my office and he has an autism diagnosis, I have to ask myself, what else does he have? Because in terms of anxiety, about 75% of them may have anxiety or gastrointestinal symptoms or mental illnesses. And those are more or less easily recognized. I said easily in quotations, but symptoms and signs of autonomic disorders are more difficult to find, and they can be disabling, and they need to be treated because they add to the morbidity and mortality of the subject. So that's one of the things that I wanted to add. And the other one, when she was talking about exercise, there's a deep need for exercise in autism. If they can do it, it's excellent. But once you receive a diagnosis of autism and you get a prescription from my pad, the next one is going to be a prescription for exercise. And obesity, the sedentary life, going back to your room and playing with your computer all day long, those are major side effects of our society that are impinging on the health of our autistic children. And together, they have a synergistic effect, making things worse. Obesity, sedentary life, all of a sudden it procreates diabetes, which is attached to autonomic disturbances. It all goes together. You need to act promptly from the very beginning.
And I will also add a little bit to when it comes to, and I will say stress the cardiovascular exercise when it comes to these autonomic disorders. I mean, strength training and flexibility are very important. I'm not downplaying those. But in terms of the autonomic disorders and cardiovascular exercise, I've found generally that the exercise tends to act more like a pacemaker for training. So when you've got this dysregulated, essentially cardiovascular output, which can sometimes be very subtle, it can really help in retraining that dysregulation. So that's why we say in particular cardiovascular is very good.
All right, so the next question is about TMS. Can individuals on the severe end of the spectrum tolerate TMS? Doesn't it require sitting still? So is this really a treatment that is for a certain subset of?
Again, that's a very good question. You know, all of the clinical trials thus far have used high functioning individuals for that very same reason. Patients have to actually sit still. They have to tolerate usually the recording of outcome measures because part of the research is doing an EEG. And it may be cumbersome. We used to bring our patients repeatedly to clinics in order to accustom them to the use of a head-net device. And still we had a lot of problems. One patient only wanted electrodes if they were green in color. And another one, after having been using the net for a period of time, he ripped the net out of his head and destroyed the recordings. But I mean, that was a very expensive piece of equipment that we needed to replace. So for all of those reasons, and for the fact that many of the patients need to comply and be obedient, respectful of the environment, we try to accommodate them. The parents are there, sometimes even their therapist, everybody necessary to calm them down. But they need to sit in front of a computer, answer questions, press keys and whatever. So we have actually been working with people at the higher end of the spectrum. I can tell you that we have had experiences with people that are more severely affected, and we haven't had a good experience with them. Many of these patients actually suffer from brain dimorphisms. They have developmental abnormalities within the brain. They may have heterotopias, islands of neurons that didn't migrate properly to the cortex. They may have relentless seizures. You cannot fix anything of that with TMS. You cannot fix anatomy with a physiological intervention. Being very truthful, sincere, my grandson, he was the first person diagnosed with an NGLI1 mutation, and he's syndromic autistic, and he's severely affected. He lives his life in a wheelchair, and I haven't been able to treat him with TMS. No?
Manny, thank you for sharing that. Yeah.
Mm-hmm.
So one more question. Emily, this one's for you. They're asking about the connection between anxiety and OCD and how that relates to all of this. Is OCD the same as anxiety? Is this, are there any indications about this specifically related to what you were discussing today?
Sure. Yeah, I mean, there's definitely a relationship. You got a lot of comorbidity, of course, with both of those conditions. They occur a lot in autism, obviously. I would say probably the main thing that differentiates them is probably the functions and the areas in the brain that are actually responsible for them. So with OCD, you tend to have more of this frontal cortex and the limbic system, which is kind of your motivational area, your emotional area. There tends to be kind of an overactivity of certain neurons within within that network, within that system. And so, but in terms of anxiety, I mean, obviously that's much more difficult to locate in the brain. I mean, you certainly have things like the amygdala that are involved in terms of the fear response and things like that. But then obviously we're talking about things like the autonomic system, which is out in the periphery of the body. So, but I would say that where the main overlap is that there tends to be, they tend to be hyperexcitable. The neuronal activity tends to be hyperexcitable. So, you know, you're really just talking about different systems in the brain, but the kind of the same fundamental underlying kind of neuron dysfunction is very similar. So that's why you have things like anxiety, hypersensitivity, OCD, you know, seizures that all kind of have some similarities in terms of the physiology of the neuron, but they're hitting different areas of the brain, and so they're leading to different behaviors, if that makes sense. So that's kind of how we, you know, I've kind of envisioned that overlap, and I think why you see a lot of comorbidity between these different conditions. So hopefully that addresses that question.
Okay, another question. I know I'm going a little over on time, but we have so many questions. I hope you guys can hang in there a little longer.
No problem.
A question about just heart rate monitoring. So is there a wearable or portable device that can be used to monitor that on a regular basis?
Yes, there are many, and it's actually
even just even just the Apple Watch is a really decent heart rate monitor. Just saying that. So
yeah, we started using wearable devices about 10 years ago when we had the opportunity to follow patients in the real life environment. We were participated in a school that was in a mall, and we had the patients actually wear them while they were interacting outside, and it actually was extremely useful because it allowed us to not only desensitize the patient many times, we actually used it with many computer programs for desensitization, but also to be able to intervene in some occasions when the patients were losing control. So there are many available, yes, and you do not need even a prescription or anything to obtain them. You can do a quick search on the internet and you will find them.
Okay, so those regular monitoring devices would, if your child or loved one will tolerate it, are completely acceptable. You wouldn't need a special device.
No, and the other thing is that because what they usually do is that they measure electronic voltage, and the electronic voltage detected is minimum, and then you have to amplify them by the apparatus themselves. There's very little risk to the patient, so it's not at all a high-risk device. It's many times using either a computer at one end or a 9-volt battery for some of this equipment. So it's a very low-risk device.
And I will say, for non-research purposes, the Apple Watch is really great. It gives you a good idea of heart rate if you just want to take a look at it through the day, because I know anxiety and issues like that are not particular solely to autism in our families. We got a lot of anxiety through our families for a variety of reasons. So these are really great. And I know the newer ones also have EKG, and you can keep track of pulse ox. I mean, you've got all sorts of stuff with the new iWatches, and they're a great way to keep an eye on those kind of things.
That the only thing with the watches is that they may not be able to provide complementary measures like an electrodermal response. Okay, so they only gave you one view or one perspective of the autonomic nervous system. The other thing about many of these devices like watches is that they will give you an interpretation of the linear parameters, like for heart rate, but it doesn't tell you about the standard deviation of the heart rate, or it doesn't divide the heart rate into high frequency and low frequency components. So for that, you would need more specialized equipment.
Yeah, there's a lot missing. But I will say some of the other things, and this is, I am not paid by Apple, so don't think that in the first place, but I just know with the Ehlers-Danlos community, and there's a lot of autonomic disorders, this is usually the go-to. I don't recommend stuff like Fitbit. For some reason, the heart rate monitor is not as accurate. This tends to be the most accurate on the market, so that's why we tend to go for it. So